Good afternoon, everybody. My name is Dr. Sandra Fucili, and I'll be presenting to you today the results from our study entitled Current Oral Feeding Management Approaches in Neonatal Intensive Care Units, results from a Canadian national study. Before I begin, I'd like to take a few minutes to thank the research committee for the opportunity to present our research projects, as well as my two investigators, Ms. Alyssa Alguire and Ms. Janine Kowalski, for all the efforts they've put into this research project as well. We also like to report that we have no conflict of interest to disclose. As well, no financial support was received for this research project. Advances in medical technology has increased the survival of infants who are born with a complex medical condition such as prematurity or congenital heart disease. Consequently, majority of these kids necessitate neonatal intensive care. Studies have found that up to 40% of infants who require neonatal intensive care often experience difficulties with oral feedings, such as disorganized sucking pattern or inability to coordinate suck, swallow, breathe, leading to episodes of apnea, bradycardia, and oxygen desaturation. These oral feeding difficulties often impede on the transition from full tube to independent oral feedings and also extend length of hospital stay. The reason being is because independent oral feeding is often a criteria for discharge from the neonatal intensive care unit. Therefore, effective management strategies of oral feeding, including when to initiate oral feedings and the progression from full tube to independent oral feeding, is essential in the neonatal intensive care unit. It is well established that variations in practice, and in particular oral feeding management practices, result in lots of inefficiencies, and this in turn can impact the acquisition of independent oral feedings for infants. At the moment, the oral feeding management practices that are practiced among Canadian neonatal intensive care unit remains unclear. Thus, the aim of this study was to evaluate the oral feeding management practices, in particular the initiation practices that are used, as well as the advancement from full tube to oral feeding practices that are used across Canadian Level 2 and 3 NICUs. To attain this research objective, we conducted a national online survey among Level 2 and Level 3 NICUs across the 10 Canadian provinces. A total of 65 NICUs were invited to participate in this online survey, 34 Level 2 NICUs, and 31 Level 3 NICUs across Canada. The participants included occupational therapists, physical therapists, nurses, nurse practitioners, neonatologists, or speech-language pathologists. The participants had to have had knowledge of the oral feeding management practice in the NICU. Our online survey consisted of 4 sections. The first section entailed questions with regard to hospital demographics, such as bed size, if they were university affiliated or not, and whether they had a designated therapist or professional that managed oral feedings. Our second section involved questions regarding clinical approaches they used for the introduction of oral feedings, as well as how they advanced from full tube to independent oral feeding. And the last question consisted of strategies for management of oral feeding difficulties. Our study protocol was reviewed and approved by the Health Sciences Research Ethics Board here at Queen's University. We had an initial pool of 65 Level 2 and Level 3 NICUs. Of those, 59 agreed to participate in our online survey. Of the 59, 48 agreed and completed the survey, and thus making our response rate for the survey to be 74% of the 65 units who were invited to participate in our study. In terms of respondents, a response rate across the NICUs across Canada, we have a fairly good representation of 9 out of the 10 provinces in Canada. Here you'll note a 0% from Newfoundland and Prince Edward Island. I'd like to emphasize that these two provinces do not have a level 2 or 3 NICU, and thus could explain or explains the 0% response rate that we found in our survey. The majority of our respondents in terms of provinces was from Ontario, and that's 35%. And that is in line with the number of units that are present in the Ontario, whereby the province of Ontario has the most number of level 2 and 3 NICUs across Canada, followed by the province of Ontario, 10%. In terms of the results, in terms of the approaches they use for both initiation and advancement of oral feedings have been pulled together because similar findings were found for both. In terms of the approach for practice, whether it was just one individual health professional or a multidisciplinary team approach was used, the large majority of participants, 34, which is 71% of our respondents, indicated that they use a multidisciplinary approach to initiate oral feedings and to advance from full tube to independent oral feedings. Similarly, a family-centered approach was used by the majority of our respondents, 38, which translates to 79% of respondents, indicated they used a family-centered care approach and involved the parents in the decision-making to start oral feeding and to advance oral feedings. In terms of the practice approach they used, we found that a large majority of the units used a custom-designed general unit guideline to determine when to start oral feedings and how to advance from full tube to independent oral feedings. And that was 22 of the participants, 46%. Some indicated 16, which translates to 33%, indicated they used evidence-based feeding protocol, such as the SOFI protocol. And these are protocols that give you some general guidelines of how to start and advance oral feedings. And very few, only one respondent, 2%, indicated that they use a standardized, validated oral feeding assessment, such as the NOMAS. Our results in terms of the clinical factors that they considered to introduce and advance oral feedings, again, similarly, we found that a similar clinical factors were both used for the start initiating of oral feeding, so we pulled the results. This national survey reveals that majority of respondents use behavioral cues to start oral feedings, such as infant crying, infants waking by themselves, and infants showing signs of rooting, or any other clinical signs that they felt the infant was ready to start oral feeding. They also use suck, swallow, breathe coordination, respiratory stability in terms of their oxygen saturations, respiratory rate, and heart rate, stable vital signs where they didn't have too many episodes of apnea outside of enteral feedings. They also use Did they have any feeding intolerances? And if they did, they would not initiate oral feedings. Gestational age was a factor that they considered, as well as weight, whereby did they show adequate weight gain in a 7-day period. In terms of follow-up care, 31 NICUs, so 65% of respondents said they addressed feeding problems only until hospital discharge. So very few provided further follow-up care on feeding issues after hospital discharge. So what these results entail is that this survey really highlights the continued variation in oral feeding management practices across Canadian Level 2 and 3 NICUs. We also found that the large majority of units are using a multidisciplinary care approach, and they often involve parents, so a family-centered care approach when it comes to deciding when to start oral feedings and when to advance oral feedings. The families were included. What we also found was a widespread use of custom-developed unit guidelines to initiate and advance oral feedings, and these guidelines are not based on any evidence-based practices. Interestingly, what we found in this study is that there was a shift in using gestational age alone towards more using infant-driven behavioral cues to guide oral feeding initiation and advancement. And this is very different in terms of our findings from our previous survey that we conducted in the early 2000s, where we found that gestational age was the main clinical factor used to start oral feedings and to drive or to transition from full tube to independent oral feedings. So there's been changes in clinical practice since then, where they're using mostly infant-driven behavioral cues and looking at infant behaviors in terms of when to start and advance oral feedings. In comparison to our previous study, most NICUs continue to manage oral feedings only until hospital discharge. Very few will provide follow-up care post-hospitalization. And this is quite important given that a large majority of infants who have been in the neonatal intensive care unit for a prolonged period of time tend to develop oral feeding difficulties or pediatric feeding disorders post-hospitalization. In conclusion, the findings from this national survey emphasize the need for the creation of a standardized, evidence-based guideline to ensure consistency and to optimize oral feeding outcomes for infants who are in the NICU. And this is based on studies done on enteral feedings, whereby they found if the use of a standardized enteral feeding protocol, infants presented with optimal feeding performances, they tolerated tube feedings better, and they achieved full tube feeding or full enteral feedings sooner. And so I propose that the same approach is used for oral feeding, whereby we create a standardized and evidence-based guideline to ensure consistency across units, because as this survey revealed, there's a variation in practices across all Canadian ICUs. And this will optimize the oral feeding outcomes of infants in the NICU, which hopefully will lead to faster achievement of independent oral feedings, and also consequently earlier hospital discharge for the infants who are in the NICU. The second conclusion that can be drawn for our national survey is, given that majority of units or respondents still only follow infants up until hospital discharge. And given that there is large body of evidence that infants who have been in the NICU for a prolonged period of time can develop pediatric feeding disorder, there is an increased need to improve post-discharge follow-up for feeding, in particular for infants who have been in the neonatal intensive care unit for a prolonged period of time. And I'd like to take a few moments to acknowledge truly all the neonatal occupational therapists, physical therapists, nurses, as well as nurse practitioners who responded to this national survey. I appreciate the time they've taken from their busy schedule to answer this survey. These are our references. And I'd like to thank everyone for listening and to being part of this research study. And if you have any questions, please feel free to reach out to me to the email that you see on the slide. Have a very good day and enjoy the conference.